she can continue with her presentation on ARDS. And Dr. Sharmili is leading a very big critical care unit of Apollo Hospital in Odisha, in Bhubaneswar, the capital of Odisha. It's one of the states in India, coastal states. And she has special interest in this subject. So I requested her to enlighten us on ARDS. Dr. Sharmili, please, if you continue and share your slides.
Thank you, Dr. Saad, for giving this opportunity, and hats off to you for your sincere dedication and efforts for continuing these academic sessions. And I would thank to Dr. Ranjit for kind words of introductions. With that, I would move on to share my screen. You have to stop sharing, actually, Dr. Ranjit.
Okay.
Now, I have been, after this two excellent sessions by Dr. Vikram and Dr. Ranjit, they have set the perfect ground for talking about one of the more complex aspects of mechanical ventilations in ICU, and that too in ARDS patients, that is acute respiratory distress syndrome patients. Now, as we have seen the growth of critical care in the last, 4 to 5 decades, we have seen how we have come to understand the aspects of the pathophysiology of ARDS, its management better with passage of time. Yeah.
Excellent. Thank you.
So these are the learning objectives of the session today. And now, what is the basic definition of ARDS? This has been lately revised in the Berlin conference about as being an acute meaning, as an acute or having an acute onset, meaning onset over a period of around less than 1 week or less. There has to be presence of bilateral opacities, we must be present, and may be detected either on the chest X-rays or the CT scan. PF ratio is usually less than 300 millimeters of mercury with a minimum of 5 centimeters of PEEP or CPAP. You have understood what is PEEP or CPAP from the previous 2 lectures. And these opacities must be fully explained by the cardiac failure or fluid overload. Now, if you classify it as according to their severity, it is usually classified into 3 categories, that is mild, moderate, and severe. And you see, if you combine the moderate to severe categories, they constitute over 80% of all cases of ARDS. So usually it is a serious disease entity, which needs more detailed attention in terms of management in intensive care unit. Now, coming to the causes of ARDS, it could be mostly parenchymal or, either pulmonary or extrapulmonary causes. Now, coming to the pulmonary causes, where it is directly caused by lung injury, either due to infections or due to aspiration of gastric contents, air or fat emboli. There could be toxins also, which could be inhaled and directly cause pulmonary damage, thereby leading to ARDS. Accidents like near drowning or polytrauma, where there is direct injury to the lungs or thorax, can cause lung contusions. And mind you, also it also gets affected in reperfusion injuries after long transplantations or after thrombectomy surgeries as well. Now, indirect injuries are also quite constitute as big segment of this kind of patients who ultimately develop ARDS as part of multi-organ failure. So sepsis and septic shock continues to lead the list in this indirect list of pathophysiology. Polytrauma, we discussed acute pancreatitis, and for that matter, or any condition that can cause SIRS, that is systemic inflammatory response syndrome, can actually also cause ARDS. And the list is really long. Now, we have gone through the Berlin definitions of ARDS, which was released in the year 2018. And just a quick note about the distinctive features of COVID-related ARDS, or which we call CARDS. The unique features of this COVID-related ARDS have been severe hypoxemia with preserved lung compliance in many of these patients. And these severely hypoxic patients have remarkably done better compared to the other non-CARDS ARDS patients. There has been significant expression of silent hypoxia in this group of patients. They were severely dyspneic, and they could be also hypocapnic, normal hypocapnic. In this context of COVID-19 pneumonia, there was a question initially about different phenotypes of CARDS or COVID-related ARDS, but later on it has not been able to catch more attentions. There were talks about L and H type phenotypes of pneumonia, but later on, towards the second wave of the pandemic, we came to understand that management remains more or less the same as we deal with any basic case of or frank case of ARDS. So in the context, I'd like to talk about few of the terminologies which we generally come to discuss when we talk about the lung mechanics, especially during ARDS ventilations. These are called lung stress, strain. I'll not go into the details of this because ARDS is a subject where you can spend an entire day in discussing mechanical ventilation of ARDS. So in this 25 minutes or 30 minutes that we have, I'll just give a consolidated concept about the easy ways how to initiate and continue ventilation support in these patients. So what is stress? It is the transpulmonary pressure. And how it is measured? It is the airway pressure minus the pleural pressure. Again, the other one is the strain. Now, what is strain? It is the ratio of volume change to functional residual capacity. So when pressure or air is forced into the lung alveoli by a positive pressure during inspiration, the volume of the alveoli changes. Now, this extent of change in shape of the alveoli compared to the previous shape is this ratio is essentially called the strain. So both these matter, and why it is important to discuss is because these are the two components which essentially decide about the ventilator-induced lung injury. And also there is one term called patient injury or spontaneous lung injury induced during the spontaneous hyperinflation. Now, what is pleural pressure? It is in general difficult to determine the accurate value. No one can determine it accurately from the ventilator point of view. But from the for the pulmonary mechanics that we have studied in animal models, we know that this changing in pleural pressure can affect the central vascular volume and thus can affect the circulation of other vital organs. Because remember, when the pleural pressure increases, it draws more vascular volume to the thorax. Thereby, the blood is withdrawn from other vital organs like intra-abdominal circulations. So organs like kidneys, liver, and bowel, they will suffer from ischemia. And especially this phenomenon is seen or appreciated in patients who are very tachypneic in respiratory distress and not been intubated. So if they're in the spontaneous mode, either with or without non-invasive ventilation, they train to generate a lot of positive pleural pressure, thereby increasing the venous return to the thorax and actually also can worsen the edema in the lungs. I just talked about this SILI, that is self-inflicted lung injury, along with the ventilator-induced lung injury once the patient gets intubated. Not go into the details of this. So now straight coming to mechanical ventilation in ARDS patients. This could be broadly divided into two types, non-invasive ventilations and invasive ventilation. Now, non-invasive ventilation has now come to play a greater role in the management of these ARDS patients in the initial phase now, compared to as it was before. And in the pandemic times, when the entire world was, struggling to give any kind of therapy or support to these patients who got admitted to the hospital on different healthcare setups, there we have actually seen increased usage of this non-invasive ventilation in this group of patients. So, and the other one, of course, when they are proceed to the severe category, they get intubated. So in this non-invasive mode, we'll discuss about the conventional ventilator, which has got an NIV mode, the high frequency nasal cannula, in even the smaller BiPAP machines of different types have been used in the pandemic in these patients. So we'll quickly see that. So initially in the mild ARDS, as you saw, at least 30% of all ARDS cases in literature belong to mild ARDS cases. And initial treatment, depending on the etiology, they also respond to just the minimum intervention and supportive therapies. So initial phase, actually, it still qualifies to give them oxygen therapy through cannula. And these are the ones, the cannula, this is a face mask, and this is the reservoir mask again, which has been also used in huge numbers during the pandemic. And they can provide up to 80 to 90% if when they're administered. So now when you proceed to moderate ARDS, you have to institute positive pressure ventilations. For this, along with the conventional ventilators, people have used this kind of small BiPAP machines with either CPAP modes or BiPAP machines. But what are the disadvantages? Because if the etiology is actually infected, as it was during the COVID-19 pneumonia or the pandemic, it carries the great risk of increased aerosol generations. And if you have attached it to the patient, you are not monitoring the progress and the performance of the patient, it might actually delay intubation and thus has shown to increase mortality solely due to delay in the institution of invasive mechanical ventilations. So early intubation in progressive respiratory failure remains the key. Now, what about this HFNC? I think most of you are familiar with this. Just quickly talking about it, it is, it is user friendly. We have a gas source. This is an active humidifier, and there is an admixture of gas and oxygen, and it is attached to the patient with a nasal interface, as you can see here. So a lot of flow is generated, and it provides positive pressure with high flow, better tolerance in claustrophobic patients. Because remember, in NIV, when there is a mask is applied to the face, many patients feel claustrophobic and thereby they're uncooperative. But this is usually better tolerated by these patients. But again, disadvantage is that is increased chance of generation of aerosols, higher usage of oxygen, and this was actually a point during the second pandemic where few of the major cities in India had positive oxygen cylinder because hospital admission rate was higher in the second wave, and it was felt that actually HFNCs are consuming more oxygen. I mean, that remains a point of debate. Many patients also do not cooperate because the higher amount of flow which is generated at the nostrils makes the nose very dry. So many patients also do not feel comfortable, and if the humidity is not appropriate, if the temperature is not appropriate, they may not feel comfortable. And due to the cost, it actually may not be available in most of the centers, the peripheral or the smaller centers. So indications are, in the mild ARDS, as I said, patient who are cooperative and alert enough, and they have moderately high oxygen requirement, they have mild to moderate respiratory distress, and if they have coexisting pathologies like COPD or left ventricular dysfunction or obstructive sleep apnea, they actually tend to tolerate the non-invasive ventilation better compared to other patients. And somebody who has got a terminal illness, and if you are already have a plan in place about capping or non-escalating their extent of therapy, non-invasive ventilation is also a choice. Of course, it is contraindicated in patients who are very sick, who are drowsy or non-cooperative, and somebody having hemodynamic instability or multi-organ failure are certainly not the candidates for NIV. So when you give NIV, you have to monitor all these parameters. You need trained and skilled staff. Issues are, again, you have to be very careful in monitoring the progress of these patients. Nutrition could be an issue if they're more dependent on the NIV. Humidifications, secretions, and physiotherapy is also a problem, because if they're constantly attached on the NIV, you cannot suction and remove the secretions if the patient is unable to cough and take it out effectively. And invariably, that would result in a delay in conversion invasive ventilation, increasing mortality thereby. So once the NIV fails, we have to go for intubation and put them on invasive mechanical ventilations. Remember, in ARDS patients, there has been always a concept of baby lung, because it is a diffuse disease and both the lungs are diffusely affected by the pathophysiology. So whatever lung remains aerated, that is the lung or the alveoli. Those are the group of alveoli which are getting filled or expanded during delivery of the tidal volume. Those parts of the lung which are absolutely where the alveoli are collapsed or partially collapsed, they are actually not utilizing the tidal volume which is being delivered to the lungs. So suppose we are setting a tidal volume of say 6 to 8 ml or 8 to 10 ml per kg in the previous 20, 30 years ago. Those tidal volume used to go to the entire lungs. So now the alveoli which are already collapsed or partially collapsed, they are not getting distended by that or not utilizing that air to get distended. That much air is actually being used to distend the alveoli, which is in only part of the entire lungs, to get expanded. And this is a baby lung, thereby resulting in over distension. As Dr. Ranajit was showing his graph, that pressure volume graph, at one point of time, if there is over distension of the alveoli, it causes fall in compliance. So in this context, there has been a landmark trial. I think most of us are aware of this protective lung ventilation trial conducted by ARDS-NET protocol team. That is regarding low tidal volume ventilations. I'll just try to make it simple. Here the settings are mostly kept in when you start putting a patient of ARDS on invasive ventilation. So you usually set a control mode, either pressure or volume control. As Dr. Ranajit very nicely explained, that how you're either setting the control mode either in the volume or the pressure mode. That is both way possible. It is not only volume, neither only pressure. Both can be utilized for this purpose. A tidal volume of around 6 ml per kg is initially set. PEEP you have to set according to the ongoing oxygen requirement. Other parameter is the respiratory rate and the peak inspiratory pressure, which is ideally desirable to be kept less than 30 centimeter of water. We'll talk about the role of prone ventilation and others in the subsequent slide. Sorry. In the volume control mode, say for 60 kg adult patients, as I said, the tidal volume will be in the range of say 6 to 8 ml per kg. Respiratory rate for these patients initially is kept around within 20 to 25 breaths per minute. I ratio is set, and usually we set a slightly higher PEEP depending on the severity of the oxygen requirement. And again, the target remains less than 30 centimeter water. Pressure control, similar targets are there. So targets are pressure, tidal volume, and the peak inspiratory pressure. And of course, you have the oxygenation targets as well. But it is, very clear dictum or principle which is advocated in the ventilation of ARDS patients that one should not aim to achieve normal blood gases in ARDS, and it should always be titrated according to the goal. So now this is a chart which is from up to date, which shows how you set the initial tidal volume. This is more or less, keep it simple, just you have to proceed setting the first tidal volume as 6 ml per kg. Check your peak pressures, check your PEEP, check your blood gases, and accordingly move. You can easily refer to this if you wish to. So what are the targets of mechanical ventilation in these patients? Permissive hypoxia is a concept which has always been practiced in this subset of patients. So it always been a question of debate how low oxygen can be tolerated, how low can we go in terms of accepting the PO2 values. So it is around said to be more than 50 to 60 millimeter of mercury with good perfusion status is acceptable. And in terms of SpO2, more than equal to 80 to 85% is also acceptable. Regarding permissive hypoxia, if the pH is remaining above 7.5 to 7.25, this is also acceptable. But if the perfusion status remains good, and how do you assess that? By doing blood gases, looking at the lactate levels, by end organ perfusions like the urine output. But a word of caution is that if your patient also has got concomitant, say, brain injuries, traumatic brain injury, suppose a patient has polytrauma, as I said, that polytrauma also can be a cause of, extrathoracic or extrapulmonary cause of ARDS. So if there is a concomitant brain injury, or if there is a stroke, or there is a seizure, it is not a good idea to allow permissive hypocarbia, because then your brain is also getting damaged. Always regularly monitor these patients with blood gases. Blood gases ideal are arterial, but for any reason, if you're not able to get at ABGs, you also can manage with venous gases, because these can give you a rough idea about the pH and the CO2, the carbon dioxide levels at least. FI2 now, when you started ventilating these patients after 48 to 72 hours, the airway pressures are to be preferably kept less than 30. FI2, if you can bring it down equal to or less than 0.6, PEEP starts reducing. So you are achieving success in managing these patients. If not, you have to escalate your therapy. Now, what are the rescue therapies for refractory hypoxemia? The one and only, most established and accepted modality of management in refractory hypoxemia has been prone ventilations. There have been series of papers and trials in this context by Gattinoli. Most of the work has been done by Dr. Gattinoli et al. From Italy. So it is based on a very simple concept. See, when a patient is lying supine, these are the alveoli. You see, the basal alveoli are absolutely collapsed. Now, when this patient is made prone, all this alveoli have, those who are partially collapsed, they've opened up, and those who are absolutely collapsed, they have also opened up. So thereby the aerated lung tissue has increased. Now the baby lung, which whatever percentage it was, it has further expanded. And also the perfusion increases to the dorsal part of the lungs. So as a result, it improves the VQ mismatch. Now what is the protocol? It is usually conducted 12 to 16 hours usually, and can extend up to say 24 hours also if necessary. We have done this during COVID pandemic times, because sometimes the result is so good, you'll be really reluctant to make the patient supine, but it has to be done to give them usual nursing care and also for care of the pressure points. And up to 5 to 10 sessions till the patient improves. Of course, you have to take care of all the pressure points, and pressure sores should not develop in the dependent parts. Contraindications are few, like if a patient is hemodynamically unstable on high doses of vasopressors, If the hypoxia actually has not responded, even after pruning, then there is no point in keeping the patient prone with more efforts. If a patient is on further organ supports like dialysis is being done, there's an abdominal distension for whatever reason, or if there's a trauma, suppose it's a part of polytrauma, if the patient has got hemoperitoneum and also lung injury, you cannot prune these patients. And similarly, if they have a flail chest also, you cannot prune this group of patients. So challenges of prone ventilations are there. It is quite labor intensive. Those who have done it would understand that at least 4 to 6 patients are needed, because you have to hold and guard the patients from head to toe. Someone has to hold the tube, all the lines have to be taken care. And then with much caution, you have to make the patient prone, and while making supine also. Obese patients, it is very, very extremely challenging as well. Tube dislodgement chances are very high, very difficult to provide mouth and line care during prolonged prone hours. And if these patients have to go undergo dialysis, again, it is difficult to do the lines in the prone positions. And if any patients gets cardiac arrest during prone position, it is very, very difficult affair, because we can give that, theoretically we can give CPR in prone position, but it is extremely difficult unless patient is expert, and most of the team members will not be good at it. So we have to end up making this patient supine, which wastes a lot of precious times. So always ensure good venous access. I repeat this line because this is from practice point of view, this is very important. It always ensure very good venous access, preferably central venous access and arterial lines before making the patient supine. Because once the patient is prone, and there are a good chance that peripheral veins might get stretched and might come out, and it will be again very difficult to do central line. So always do the central line, and a good arterial line fix them very well before proning them. This is a trial. I just wanted, it's a good actually meta-analysis rather, we just looked out around 9 studies, and you see all these are in favor of prone. This section favors prone. All these have favored prone, both in terms of improving hypoxia and mortality. So it is one of the most accepted intervention in severely hypoxic ARDS patients. And what about recruitment maneuvers? It has been actually the medical fraternity or the critical care fraternity has remained much divided on this, on this aspect of recruitment maneuvers for more than 2 decades now. There has been, whenever whoever are proponents of this recruitment maneuvers are really, propose this to in their attempt to open the collapsed non-aerated alveoli and also partially collapsed alveoli by using high PEEP. It may improve oxygenation, however, transiently, but it does not give sustained effects. And thereby, therefore, it makes it necessary to assess recruitability in these patients before we actually think of instituting recruitment maneuvers, because it is not very safe or not without risk. There is, in fact, very high risk of barotrauma in these patients, and also a stable patient might go into hemodynamic instability due to rise in the intrathoracic pressures. And a couple of studies which have been done in this respect has not shown any mortality difference. How do you assess recruitability in these patients? Now, let me make it clear that it is not necessary that in all ARDS patients where we institute mechanical ventilations, it is necessary to assess all these patients for recruitability. By default, when you're setting the ventilator for low tidal volume or lung protective ventilations, we start as for the recommendations, you keep a moderately high PEEP around 8 to 10 for all these patients and see the response. If a patient is responding to that amount of higher PEEP, you can try slowly increasing the PEEP further as if your FIO2 requirement is increasing and see the response. But however, if you're sorry, very much interested, you can look at the hysteresis of the low pressure volume curve, as Dr. Ranajit explained. You have to really have a low flow on the ventilator to see the study that hysteresis graph. And also recently they have found out one RI ratio, that is recruitment to inflation ratio, which can also tell you about the recruitability chances. We'll not discuss this aspect. Now, what are the imaging modalities? Just for the sake of it, I'll mention this. CT scan is one way where you can, inflate the lung. This is basically feasible in, say, in setups where you have bedside or mobile CT scans, which is not present in most of the countries across the world. So if you have a bedside CT scan, you can take cuts of their lungs, give a high pressure, see how much is the distension. And then you can see if the lung is recruitable or not. Ultrasound again can be used for this purpose, but ultrasound cannot actually differentiate between collapsed alveoli and alveoli which are filled with edematous fluids. So ultrasound is not a preferred modality for assessing recruitability. There is something new aspect technique called electrical impedance of thorax, EIT. This is available in some of the models of Hamilton ventilator. This, if you are applied to the chest as ECG leads, they can give you some impression about which parts of lungs are actually recruitable, or if you have more area which can benefit from using higher PEEP. And in general, it is seen that ARDS of extrapulmonary pathology has got better recruitability than pulmonary etiology. Now, how, if at all you are doing it, how do you do it? It is a step ladder or decremental method. In step ladder method, what do we do is we increase the PEEP gradually. Say, suppose you have set it at 10 or 12, you gradually go up to 40. Or in the decremental method, you keep the PEEP at increase the pressure to up to 40 centimeter of water, keep there for 40 seconds, not preferably for more than 60 seconds, and then see what is the difference in the saturation and the hemodynamics. If a saturation is improving and hemodynamics are stable, then the patient would benefit from recruitment maneuvers. But if not, it is no point in trying that repeatedly. And actually, it still runs the high risk of barotrauma in these patients because, as I mentioned about this, transpulmonary pressures get severely altered in this process. So the quest for optimal PEEP has always been going on for last 3 decades. And Dr. Ranjit rightly pointed out, medical fraternity is divided about it, about using a low inflection point, upper inflection point, and even the upper deflection point. Why PEEP is so favorite? Because simply physiologically, it reduces the chances of airspace occlusion by mucus plugging or exudates. It promotes translocation of edema fluid from the airspace into the interstitium. And patients who have got high recruitability, as we are discussing, will definitely benefit from high PEEP, but not all patients again need high PEEP. So you keep it in the middle range and see how the patient responds. Accordingly, always we can titrate. We do not need always these higher modalities or the technology to assess recruitability and the patient behavior. And as my previous speaker mentioned, the best way to learn and handle the ventilator is to be by the patient bedside and work with it. There is a PEEP and FI2 chart is present as per the ARDS NETS protocol chart that always you can see as a rough guide. Now, what is this? This is a trial which was published in around 2000, sorry, 8, which looked at ventilation strategy, compared ventilation strategy using low tidal volume, which was, they came out into the year 2000, versus recruitment maneuvers versus a strategy which used recruitment maneuvers and high positive pressure for acute lung injury and ARDS patients. Just give me a moment, I'll have some. Yeah, sorry for the interruption. So what did they found? So in one category of patients, they used only the low tidal volume of ventilations in a group of ALI and ARDS patients. To the other category, they applied this low tidal volume along with this recruitment maneuvers and high PEEP. And you see the all-cause mortality, which was the primary outcome, there was no difference. Even breathing independently also, in this parameter also, there was no difference. Now, if you see this table of outcomes, all-cause mortality, of course, there was no difference. But what was the difference was this incidences of refractory hypoxemia was less in the group which received recruitment maneuvers and high PEEP, and rescue therapies also were less required in this group of patients. But overall, there was no difference in the incidences or the ultimate outcome of all-cause mortality in these patients. All other parameters like days of hospitalizations, days of intensive care, ventilation, everything was comparable. As you say, total use of rescue therapy was less, and also the incidences or episodes of refractory hypoxia were less, only this in the group. So these are not very highly advocated in the management of, recruitment maneuvers are not highly advocated in the management of ARDS patients. So somebody who is not comfortable with it is very well accepted not to go for it. Just keep it simple and go for the classical recommendations. This is just a pressure volume curve. Here, my Dr. Ranajit has already shown this. So somewhere between this point and this point, you can keep the PEEP. If you are good at studying your ventilator graphics, which you will be after this webinar series, I believe, then you can keep the PEEP somewhere between this and this point and monitor the patients, because ultimately, it is you, the clinician and the patient who is going to determine the course of the ventilation, not the machine per se. So your monitoring and assessment has a very important role to play in this patient. So what is driving pressure now? Now, this is a new concept after in 2015, I believe it was published by a retrospective analysis of a study which was already conducted by Amato et al. So it is in simply a difference of PEEP plateau pressure minus the applied PEEP. What is the target value? We try to keep it less than 20 centimeter of water, or some group say keep it as less than 15 centimeter of water. So if the plateau pressure is say 30 and applied PEEP is 10, then your driving pressure will be around 20. So the proponents or the advocates of this driving pressure, they say that it is not the PEEP or the PEEP plateau which is going to be determine the lung injury or going to protect the lung. It is actually the driving pressure which is going to be determining the extent of lung injury or preventing the lung injury. It usually there is still lack of a lot of prospective data in this regard. There was a retrospective analysis of around 9 trials, a meta-analysis in fact, where they looked at around 3,500 patients who were mechanically ventilated for ARDS. And among all these parameters or the variables, they found that driving pressure is probably has got the best predictive value for survival in patients with ARDS. But as I said, it is not still not given much weightage in the management of ARDS ventilations, and it is not uniformly followed across the world. Now, there is a lot of coming to practicality in the management of ARDS ventilation is about sedations using paralysis and using proper venous access in the management of these patients. It is utmost important to have good sedation in these patients for ensuring patient ventilator synchrony. Opioids are definitely preferred compared to benzodiazepines, as we know that benzodiazepines during the process of when you stop this, patients has got more instances of delirium. In severe ARDS cases, we have to paralyze these patients, and generally we paralyze these patients for first 48 to 72 hours. Various sedation scores are there. Whatever your unit is comfortable with, you should at least practice one of these sedation scores. And beyond 72 hours, paralysis must be stopped. You should assess patient's compliance and their wakefulness and try to reduce the sedation gradually. Never ever abruptly stop sedation in a patient with ARDS who is on high dose or high levels of ventilator therapy, because once the patient is offset, and usually these patients are on higher ventilator settings, it takes long time to come back to state of synchrony. So never ever abruptly stop ventilation or sedation in these patients. You need to have definitely good lines. I always advise my team about it. And feeding tubes and indwelling urine catheters, they have to be taken care from infection point of view. Thromboprophylaxis cannot be overemphasized in ARDS cases, and we have seen in the last 2 years that how COVID pandemic even more further induced a hypercoagulable state, and micro diffuse thromboembolism was in fact implicated as a dominant pathophysiology in these COVID ARDS cases. However, anyway, this is DVD prophylaxis is advocated in patients who are on ventilator and sedated and paralyzed. So therapeutic or even intermediate dose of heparin can be used for these patients if there are no contraindications. Always be watchful for episodes of pulmonary embolism in these patients, which might manifest as sudden tachycardia or arrhythmias or sudden fall in the saturation in a patient who has been doing well otherwise, or if there has been an unexplained rise in the carbon dioxide levels and there's a rising trend of D-dimer in these patients. We have seen this subgroup of patients a lot during the COVID times. So we have to be watchful for the small changes in the trend in your patient. 2D echo is usually difficult to position for a patient if they're in the prone positions or if they're hooked onto many monitors. But nevertheless, it can give you an idea about if there is a right RV dilatations or vascular changes are there. Steroids can be used in ARDS patients. Of course, COVID ARDS, it was recommended, but not beyond 10 days. We have used dexamethasone or methylprednisolone. However, keep in mind that prolonged use might dispose to secondary infections and hyperglycemia. Special care need to be taken about to avoid frequent disconnections of circuit for nebulizations to prevent loss of recruitment. Because once you have disconnected, the PEEP is lost. The alveoli tend to collapse. Again, when you are attaching, it might take hours together to achieve that state of recruitment again. So it is better to use closed suction catheters. HME and humidified water need to be changed regularly because in a second wave in pandemic in our country especially, we had a kind of mini pandemic of mucormycosis, and even the water in those active humidifiers was also blamed. So from infection control point of view, this needs to be looked into. Bronchoscopy for a patient in ARDS to be done only if it is going to have a therapeutic value. If you're suspecting, a kappa or a pulmonary aspergillosis or some, etiology, which you're not able to get an idea from other investigations, then you think about it. Because for a patient who is hypoxic on high PEEP and high ventilator settings, there's high chance of rapid deterioration the moment you disconnect it. And always, gown up fully and use all the protective equipments. Infective complications are always possible for a patient who is on ventilator. So ventilator-associated pneumonias or either due to bacteria or fungus is possible. Newer modes Dr. Vikram has narrated, but they have not been proven superior compared to conventional modes in ventilation for ARDS patients. And also, I would not advocate to use the lesser tried newer modes in patients who are on ARDS, and especially if they're being on the prone positions. Challenges are plenty because there is high incidences of critical mass neuropathy, critical illness myopathy and neuropathy in these patients due to use of steroids, prolonged sedation and paralysis. Timing of tracheostomy is tricky, but we have to do it at some point of time. And we can also even think of moving on to portable ventilators like AVAPs at certain stage during the evening period. So ventilator associated pneumonia bundle is important to be practiced on a daily basis. Anybody not responding to all the higher settings of ventilator prone positions, always think of ECMO as feasible early, and it ideally within 10 days from the onset of the respiratory failure. Sorry. And fast updates, never forget this for any critically ill patients who is hosted in ICU. Sugar control, all these points are very, very important in dictating or deciding the ultimate outcome. So the take-home message remains: stay optimistic when you ventilate these patients of ARDS, because if you consolidate the mortality in ARDS patients, before the COVID times, it is not too bad. Around it varies something from 30 to 60%, depending on the healthcare setups across the world. And timely institution of mechanical ventilation in ARDS patients remains crucial. Treat the underlying cause, be it pulmonary or extrapulmonary, as we saw that list. ARDS NET protocol with low tidal volume ventilation is the best approach to start with, but do not remain confined to that. If your patient is not responding, then we have to change your management according to that list, and go for other alternative modes. Prone ventilation, you contemplate early in all eligible cases early. Adequate sedation, analgesia, and muscle paralysis is must for initial at least 48 to 72 hours. Recruitment maneuvers, do not venture out to do this in all cases. Only in suitable cases, if you have the expertise, go for it. Stick to the basics all the time. And prevention of secondary infections remain the key to success. Heparin should be used for thromboprophylaxis in all these cases with or without COVID-19 infections. And remember, never be in a hurry to wean off patients who are having ARDS on ventilator, because remember, it's a diffuse pathology. It's a serious pathology. It takes minimum 5 to 7 days to improve. I mean, respond to the therapy, either if it is an infection, to respond to the antimicrobials, or even to the positive pressure which has been instituted. So it takes at least 5 to 7 days. So never be in a hurry to wind off ventilation if they're showing some signs of resolution after a couple of days. So in the evening phase also, one distinct feature, you will see a radiological lag. But always focus on your clinical assessment and the overall other supportive organ functions as you start winning these patients. Remain cognizant of futility in the appropriate cases, because it always depends on the underlying etiology. That is to be always kept in mind. If a patient is very old, has got multiple comorbidities, has got an metastatic malignancy in place, these are the patients who are less likely to do well and come out of mechanical ventilation successfully. So this has to be kept in mind. Again, one word I will tell about, because we have been always emphasizing about this low tidal volume ventilation in ARDS. Remember that all ventilation in ICU is not ARDS ventilation. Suppose a patient is coming after a traumatic brain injury or from a craniotomy or laparotomy. All these patients, you did not think of applying. These are not injured lungs. These are not diseased lungs. So you do not think of applying ARDS net protocol in these patients, because as I mentioned that this low tidal volume ventilation can cause hypercapnia, which is not good for the brain. Just aim for clinical targets of oxygenation and gas exchanges and other normal parameters, as both my speakers have narrated well. So with that, I would say that critical care is always a teamwork. And thank you very much for your patient listening. And I take this opportunity to talk about the first Eurasia conference, which is going to be hosted in India for the first time in the month of 30th June to 3rd July. It's a 3-day fully residential meeting. It's a combined venture of ESICM and ISCCM, and will be hosted in India for the first time. I invite you all to be part of this academic feast. Thank you.
Thank you so much, Dr. Sharmili, for such an elaborate description of ARDS patients. Ventilation, beyond ventilation, you have discussed more or less everything. Yes, very good message passed on. That is not to wait for with the NIVs as the PO to FA ratio is coming down. Early ventilation has to be decided. Maybe you have to paralyze the patient, sedate the patient well, at least for 40 to 72 hours. I always feel amused when we give the name permissive hypercapnia and permissive hypoxia. Permissive hypercapnia. We are permitting hypercapnia. We know very well that hypercapnia is bad for the patient when it goes beyond 70. But still, as we can't take out that carbon dioxide well, so I've given a glossy term, permissive hypercapnia. And we know very well that we can't decrease the tidal volume at least not below 4 ml per kg body weight. Now we have ACOR with us, which can help us. The extra vent study has shown we can go up to 3 ml per kg body weight. So that is the reason why you have already told that permissive hypercapnia is not good. We are permitting it because we don't know how to remove it. So this is for introspection for all the intensivists and the anesthetists who are sitting here, or the physicians, that whether should allow this permissive hypercapnia